But yeah, I mean, I categorized a couple different, what was it,
personality
like
types.
6 or 8 different personality types that I've found so far in outpatient, and different ways that I kind of get through to them and get them to kind of listen to what I'm saying and do what I want them to do. So,
Hey, healthcare providers, you're listening to the Burnt Out to Lit Up podcast. Hosted by myself, Erica, and my husband, Michael, we're an OTPT team that understands the healthcare industry's got some serious issues.
inspired by our own experience with burnout, we've made it our mission and passion to help you navigate your career in healthcare by cultivating wellness, growing both personally and professionally, and advocating for a better workplace.
Whether you are a clinician or manager, new grad or seasoned vet, join us each week as we share interviews, research, stories, and strategies that will give you the tools to go from burnt out to your most lit up self.
Let's dive in.
It's Black Friday today.
Happy Friday.
Happy Black Friday. Have you ever done shopping on Black Friday?
No, because I hate large groups of people.
I hate people.
And shopping. I actually hate shopping too.
It just seems very overwhelming to me, like sensory overload. I would not be able to handle 4 a.m. lines outside of a Target or something.
Yeah, you can sit on my laptop and get the same deals and not have to go anywhere.
Yeah, but when you were a kid, did your parents do that?
Did we go on Black Friday? No,
yeah.
Not really.
No, we never did either. One of my friends' husbands, his family tradition has, and even now, every year, no matter how old they get, they always go Black Friday shopping, 4 a.m., whatever store, Best Buy or whatever. And I'm like, damn, like they're really into it.
But how do you need stuff that often that you need to go every year?
That's true.
Because it's like, really, what are you getting? You're getting discounts on like bigger items, aren't you? Like TVs and like...
No, clothes, everything.
Clothes?
Everything.
See, but like clothes, how often do you need new clothes? I haven't bought new clothes in like several years.
I don't think anyone needs new clothes, Mike. It's just a matter of wants, because I don't need anything I buy other than the puffy coat I bought. You know, as soon as we got to San Francisco, I needed a puffy coat.
Yeah, I definitely need one as well. Everyone has those things.
I don't know what they're called, but they're very functional. They're very lightweight. They're puffy coats, and I got a really good deal. And that was like, I really needed it. And now it's so like I could fold it so easily, put it in a bag.
Super light and super wind
keeps
resistant.
You warm. Yeah, it keeps you warm. Yeah, I've never done the Black Friday shopping, and I know there's Cyber Monday, but honestly, like I just opened my email inbox this morning, and it's like, oh my God, blown up with all the sales.
You know what, those Cyber Mondays, like, it's not even that much different than Black Friday. It's just like an extension of this horrible commercial holiday we've created.
Yeah.
You know what I mean? Because it's not like the Black Friday deals you can't get online. It's not like the Cyber Monday deals you can't get in the store. So it's just like another day of dumb shopping.
Well, you hate shopping. You are so minimalist. So I'm not sure if I said this on the show before or not, but for this road trip, this new lifestyle that we have, where we're moving every few months, Mike, threw away, or I don't know if you gave away, I'm not sure what you did, but you got rid of all of our silverware. We just need what? 2 forks, 2 spoons, 2 knives?
There's only 2 of us.
No.
We don't need any more than 2.
We have 4. We have 4 spoons, 4 forks, 4 knives. But like you're so minimalist, and I'm so not minimalist.
Yeah, well, look at how good you're doing. You're gonna send a bunch of clothes home that you've never worn since we've been here.
Well, it's different because, okay, so I have all my cute Miami outfits that you can only wear, I think, in Miami. Yeah, and I didn't realize that when we move here, and the style here in the Bay Area,
everyone just wears normal clothes and has values.
Well, it's like people don't have values in Miami? Like, ¿qué está diciendo?
Mm-hmm.
Okay. That was some shade.
I'm just kidding.
No, you're not.
No, I am. It's just people. They're extra. Like they dress extra.
In Miami, it's just extra.
Super
okay,
extra.
But here in the Bay Area, I've noticed women, and I don't know about guys. I think I notice women's fashion more. Like I'm always looking at girls and like looking at what they're wearing and stuff. But whenever we go into the city, into San Francisco, the style is, how should I say this? It's like muted neutrals, things that look very casual but sophisticated, but have a really clear function. And in Miami, it's not like that at all. People have a lot of color and like these cute 2-piece sets, and like the style I've seen here in San Francisco, like even just walking around, I've seen girls wear like baggy pants, or I'm not sure, but it's like cool. Everyone looks really, really cool here. And I'm like, whoa, I don't think I'm cool enough, you know?
No, probably not.
I love style. Like, I just like, it's just two different styles. Not that one's better and not that one, like, it's just two different styles.
It's
and
probably the weather too. I mean, you can't wear Miami clothes in San Francisco in any season.
San Francisco's cold. It gets chilly. We'll be at the park and it's warm. And then like that park, what's that park called? Dolores Park?
Dolores Park.
Dolores Park. And then like we'll walk 2 blocks down and it's freezing. And then we'll walk 2 blocks another way and then it's warm. And then San Francisco is always changing.
It's in the summer, but now, I mean, this is December now, almost.
Almost December, yeah.
And it's just cold now all the time.
It's cold, yeah. Now I'm pretty cold. But it's not like you're freezing. Because I've talked to people here that...
Remember that girl on the Alcatraz cruise?
Oh my God. Que pena. How embarrassing. This girl... So we went to Alcatraz Island. Is it an island?
Yes,
it's an island, but sure. Okay. Yeah, it's an island. I just didn't know if it was called... Alcatraz is on this island. So we went to Alcatraz.
It's called Alcatraz Island.
Okay, so yeah, we went there 2 or 3 weeks ago. We took a night tour, or we got a night ferry, which was beautiful because the sunset and the Golden Gate Bridge. Oh my gosh, it was worth a million trillion words, that scene of the sunset. And so yeah, we get to Alcatraz and it was really cool. It was a night tour, so it was a little spooky at night. Alcatraz just has a really cool history. So yeah, so we're leaving. We left to go back on the ferry back to San Francisco, and it's actually like a 15-minute ride. It's not even that far. Mm-hmm. And so we're on the ferry, and there's a girl on the ferry, and it's like maybe 50 degrees. I'm wearing my puffy coat. You're wearing a sweatshirt, or you're wearing like a sweater or jacket. Mm-hmm. Everything is fine. Okay, it's not that cold. This girl is wearing like everything, like everything that you can ever possibly imagine, and then she had a blanket on top of her, like as if we were in some 20-degree minus. She was
in like a tundra coat, like with the puffy or like the fuzzy outside.
She had the fuzzy outside, but then she also had a
gloves, hot cup of coffee,
a wool hat.
Yeah, and
she had her hood from her parka or whatever over her head, and then she had gloves, and she had like a scarf, and then she had a blanket. And then I felt so bad for her because it really wasn't that cold. And then
she was clearly cold.
She was clearly cold, and she even said to her mom, "I think people are making fun of me because I'm so
yep, sure
because
are.
I'm so bundled up." And your mom's like, "You know, it doesn't matter what people think." I'm like, "Yeah, you're right. It doesn't matter what people think. It doesn't matter that I'm judging and that everyone else is judging you, because if I'm from Miami and I almost took off my coat, I was warm, like on that ferry ride. Like I could have taken off my little."
Maybe she's from like somewhere even warmer.
I don't know.
I don't know.
What's warmer than Miami?
Somewhere in Central America.
We get no. She was not from Central America. No, she wasn't.
Okay.
Yeah. What was the point of us telling this story?
I don't know. Shooting the shit.
Or no, we were talking about Black Friday and shopping and style. Okay. So yeah, I don't do Black Friday.
Yeah. What we're gonna talk about though this episode is difficult patient personalities and how you can deal with them.
Yeah,
I
so
love this, actually.
yeah, Mike is a boss when it comes to deciphering and decoding and breaking through all these quote unquote difficult patient personality types. And so we've worked in two different settings. Mike has worked in mainly geriatrics and
So mainly outpatient. So I'm a physical therapist for those who don't know. I guess you would know, but
if you're brand new, welcome. This is
yeah.
this is how we start our shows.
Yeah. But yeah, I mean, I categorized a couple different, what was it? Like
Personality types.
6 or 8 different personality types that I've found so far in outpatient. And different ways that I kind of get through to them and get them to kind of listen to what I'm saying and do what I want them to do. So
Yeah, but okay, so apart from that, like you have your experience there and I have my experience in pediatrics, and when it comes to quote unquote difficult patients, it's not just the kids, it's the parents too. So we're coming at this from two totally unique perspectives.
that's true. I don't have to worry about my patients' parents.
Most of your
the time.
patients are like 80
What I
years
do
old.
have to worry about sometimes is when patients bring kids to their appointment, which I actually find super annoying.
Oh yeah, what happened that one time where someone brought their grandchild to your appointment and they were like, without asking you, going through your desk?
I don't remember that. Was that this job I have now?
No.
The last one?
Last one. That they were just going through, not like your things.
Yeah.
I think you told me that.
I don't recall that.
So
I mean, I could totally see that happening, though. I mean, I've had kids in this job I have right now where it's like they're
it could have been this
they're
job
getting
then.
into all like they're getting the therabands out and they're like yelling and crying and stuff, and I'm just like, all right, that's all the time we have, sorry, see ya.
No, sorry, it was this job. But you've been here for a few months now, so I was thinking about, I got them confused. But I know it's really challenging and difficult patients. We're coming at this from a physical therapist, occupational therapist perspective. I'm sure if you're a nurse, if you're a physician, you have your own different set of what a difficult patient would be. And I want to start by saying that, when we're talking about difficult patients, wherever or whoever we are and wherever we're working and whoever we're treating, no matter what setting it is, we're all going to have these difficult patients. And I would like to start off by saying that we have to remember that although we can be working in this field for a long time, and it's so easy for us to just go to our coworker and say, oh, patient in room whatever is so difficult, and it's so easy and it happens, and like, trust me, it's happened to us, and no one's perfect. But in going forward about difficult patients, I want to say that we have to always remember there's a reason behind them being difficult, and we don't know what they're going through. We don't know if we're just another face that they've seen in the healthcare system, and they're just like feeling like frustrated and overwhelmed with all this. Maybe it's a new diagnosis, or maybe where a parent is quote unquote difficult because they're really fed up with their child's care, or they're just maybe in denial about their child's diagnosis. We don't know. And for children, it's a totally different set of reasons why they could be quote unquote difficult. Maybe they're tired, maybe, we'll get into all that later. But I just wanted to say that we're going to go into our experiences with quote unquote difficult patients, but I just wanted to make that clear that we know that they are patients, that they are suffering with something. And, we always, although this is going to be like a funny episode, I just wanted to make it clear that we actually it's important for you to understand that there is a reason why they're quote unquote difficult, and maybe that's how they're expressing themselves at that point in time, but there's actually other things going on behind the surface. So it's always up to us to be able to play detective and understand what is it about this behavior that is difficult. What is really going on? So yeah.
All right. Take a breath.
Okay.
All right.
Start?
Yeah. So first thing you guys need to understand is the golden rule of dealing with all patient personalities, not just the ones we're going to list off. The golden rule is you need to be a really good active listener. Okay, you want to talk about OARS?
Yeah, so OARS is an acronym for active listening. You have O, which is open questions, A is affirmations, R is reflective questions, and S is summary. So we did a lot of role playing in the class I last taught at earlier this year, which was called Human Interactions, and we did a lot of role playing. We looked at different scenarios where a doctor and a patient, like a good example and a bad example, and then we role played it amongst ourselves between the students and the other professor I was teaching with and myself. And what we learned with active listening is that it allows patients to feel heard, understood. So open questions is you're not imposing anything on them in particular. You're actually active listening, and this OARS allows you to talk a lot less and listen a lot more. And then you get the patients to self-generate what it is that maybe they need to do. So open questions and then affirmations, like you kind of, so for example, if you're talking with a patient and you want them to make some sort of change, right? Maybe you want them to be compliant with their home exercise program. Maybe you want them, in the case we watched this video, right, where this doctor was trying to get a patient to make a change about his diet. And so having the patient to self-generate, go through their excuses, maybe why they can't do this or why they can't do that, and then reflective questions, affirmations, and then, after you've gotten through a whole bit of conversation, again, allowing the patient to really do all the talking versus you can ever suggest something, then you summarize. You get the patient to understand that you understand. So both of you are on the same page, and then you've gained trust. This patient now feels more heard probably than ever before. And this patient trusts you. And so before you attempt to make any sort of change or recommend anything to a patient, and they're just going to brush you off, or just, maybe they're going to be like, you don't get it because you don't know what I'm going through. This active listening is helpful because it gets the patient to get to a place where they're ready to listen to you or whatever suggestions you have to make.
So, what I've found as a PT is like, and this is different for every profession, but from what I've found, it's like I'm typically the healthcare provider that they see and speak to the most out of any provider, right? They see a doctor, they see him for 5 minutes. They see a nurse, they might get some labs taken or a couple quick questions, and then they're whisked off to a waiting room where they wait for the doctor. Basically, with us, with PT and OT, it's like, you're the first clinician to really sit down and have more than a 10-minute discussion with them, which is really important because keeping them talking about their condition gives you so much information about how you're going to end up treating them. We, touched on that a lot in PT school about how important the subjective history was like sitting the patient down and just letting them talk uninterrupted for like 5 minutes. Even if you have opinions or suggestions, just like stay quiet, let them talk, and really be that good active listener, because that's how you get a lot more information. So there's that. Keep that in mind when we're going through all these.
Yeah. I think one time, this is just an idea we should do, not now, but like a role playing of what active listening looks like. I think that'd be really interesting. Because we did it in class, and the students were like, they were nervous about messing up or not, doing it right. But it takes practice. It really takes practice. And if you're someone that's just used to getting a diagnosis, getting a patient in, and you're just telling them what to do, because of course that's your job, you have to tell them what to do. But if you're not seeing carryover at home, if you're not seeing the change you want to see, and you're not quite sure why, I think active listening is one of those tools that in any case, in any scenario, that it's just that extra few minutes or that extra time where you're leaning in, you're caring, you're before you even tell them what you think they need to do. I think that's really important.
Yeah. So, so we have 8 different personalities, at least from what I kind of see them as. So I'll list them off quick, and then we'll go through each one and discuss. All right. So we have number 1, the skeptic. 2, the CEO. 3, the bitch. Or if you wanted to call them something else,
Let's just call it the bitch.
calling them the bitch. And that's gender neutral. That could be male or female. 4, the flake. 5, the hypochondriac. 6, the flirt. 7, the ancient. And 8, the know-it-all. All right. So let's go and talk about the skeptic. Mm-hmm. So usually, for me, this is one of the more difficult ones out of all of them. Basically, it's like the first things that come out of their mouth are like, okay, what are you going to do for me? Okay, how is this going to help me? What does this do? What does that do? I don't know about this. Are you sure? Aren't you a little young to be a physical therapist? It's like things like that. So really, it's important to have right away some really good descriptive ability when you answer those questions. You have to basically word vomit knowledge all over everything. You have to just be like, okay, this is what we're going to do. Even if you're not quite sure, even if your treatment plan is kind of maybe this, maybe that, it's it has to be rock solid. This is what we're going to do, and this is exactly why it's going to help you, even if you don't necessarily feel like that.
Mm-hmm. In my case, working in pediatrics, it was the parents oh, what are you doing? Why are you doing this? How's this going to help? And sometimes there's words, but sometimes it's also, I can also see this in the facial expressions. So
It's true, yeah.
So my thing that I've always done is really tying our activities back to a purpose. I mean, you have to do that always. You're always, everything you do has to be for a purpose. You're not just going to give a kid therapy for 5 minutes without knowing why. Anyone can observe your sessions and be, if someone doesn't know and they're observing your session, they're not going to know what you're doing. And what you need to know is, why am I doing this warm-up prep activity? How does this tie into the bigger activity we're going to do later? How does everything tie together? So as an OT, PT, speech therapist, anyone in this sort of field, you know that what you're doing, your treatments have to be tied to a specific reason, a specific purpose. So telling the parent, oh, we're working on, I'm just going to say, okay, therapy, for example, to increase this child's intrinsic hand strength, that's going to help them to hold a pencil better and improve their handwriting. Yeah. Let's say that's a goal.
Yeah. Throwing out research is really important here too. The research shows us X, my past experience tells me Y, it's those kinds of things can really reassure them and be kind of, go from the skeptic to be like, oh, okay, this guy or girl really does know what he's doing. I think part of the reason why someone becomes a skeptic is a poor past experience with the same type of healthcare provider. So really distinguishing yourself from that, or maybe getting the bottom, to the bottom of that. Actually, one of my questions that I ask in a subjective history is, have you ever had physical therapy before for this issue or for any issue? And that gives me some information, maybe they had just a really bad experience. Yeah, so that can help. And even asking that question and talking about that can be oh, this therapist did that. Oh, yeah, okay, we don't do that. That's not great.
Oh, I like that.
You know what I mean?
Yeah.
So it's really distinguishing yourself from that bad experience.
Even with kids, I've heard of parents telling me about previous clinics they've taken their kids to receive OT and PT and speech. And I remember sometimes I've been told, oh yeah, we went to this clinic and the therapist just let the kids run around, or they just let them play with it wasn't skilled therapy, basically what they were getting at. So even though in pediatrics a lot of everything we do is around play, I mean, for the most part, so you have to even more so tie everything together.
Yeah.
True that.
Yeah. Sweet. You want to move on to the
Yes,
CEO?
The CEO.
All right. The CEO is someone who's been very successful in their lives. They've been either CEOs or they've been, high level positions at whatever company or industry that they worked in. Basically, they spent an entire career telling people what to do. And that's not a bad thing. CEOs and managers and all that stuff, they have to do that. They have to, dictate things. But that, if that's your personality, if you're that super alpha kind of person, it may be difficult for you to come into a healthcare setting where your provider is telling you what to do. You have to do this. You have to do that. If you don't do X or Y, you're going to get worse, things like that. So it's like they may be a little, they may not, feel great about taking those orders, so to speak, even if it is for their own care. Basically, it's hard to keep these people compliant if they're not 100% on board with what you're telling them. The biggest way I would kind of combat this is you have to find a way to bring them down to your level, right? So they're like, if you're kind of thinking about their position, if they think they're higher than you or something, like I'm not talking about from like a pompous kind of perspective, but if they're kind of elevated, you need to bring them down. And the way you do that is to become basically friends with them. You need to be like buddy with them. You need to get on a level where you guys or girls are both talking about, this condition or issue they have, like you're just two buddies, right? They're much more inclined to take your advice and do what you want them to do if you're not talking to them from this higher perspective of healthcare provider to patient. You know what I mean?
Yeah, I'm trying to imagine that sort of scenario in my own experiences. Actually, I did want to say something really quick. I think it can be applied to any of these. You know that phrase, fake it till you make it?
Yeah. With
confidence. So this is another episode, confidence. But when I'm working with a skeptic, or I guess any of these for that matter, if
the CEO can be the skeptic and the skeptic can be the CEO.
Right.
Overlap. Yeah.
One person can have all of these things.
That's kind of true too. Yeah.
So if you're working with anyone or you feel like or anyone, it could be anyone, the confidence that you demonstrate through your body language, through the being assertive through your voice, it's going to sound a lot better than if so this is just an example. Let's say you have one therapist A and therapist B. And let's say therapist A knows all their shit. They're really ready, book smart, ready to go, new grad. But they're so shy and nervous. So every time they say something or every time they have to justify an activity or treatment, it comes off as insecure, as doubtful, versus let's say therapist B may not be the most knowledgeable, takes CEUs just to get by, to renew the license, and doesn't really care, but just kind of knows kind of what they're doing, but not really. And therapist B might be able to justify their treatments, let's say, maybe not as strongly as therapist A, but if therapist B has this 100% confidence and assurance about how they go about working with patients and families and et cetera, then you're going to most likely trust someone that displays that assertiveness. And I've seen this happen in my own experience with therapists that are really gifted and really bright, and then versus therapists that maybe they're just showing up to work every day and they're just doing the same things, but it's in their confidence that I see that they can convince a patient to do anything. Yeah. So yeah, I think
that's true. It's sometimes it's hard to just be like, all right, you have to have more confidence, obviously, as you know.
No, I know.
But like one way that you can do that, and I think that this works really good with the CEO. I've treated loads of these people. I spent 2 straight years treating patients every day, all day, just like this. I worked, in some places. Is you have to ditch the professional attitude, I think, because if you're like a provider-patient relationship, right, it's just going to become in their minds like another business transaction. And every business transaction that they've ever been a part of, they have to be the dominant one, right? So if you bring each other, you and them to like the same level, you guys are just like buds and you're talking, you build a really good, personal relationship with them, they're going to be much more compliant.
So you're building rapport with this person in a way that
like a friendship,
is more personable.
Yeah, not so much a patient
provider. Like I know
relationship.
All this.
Exactly. Yeah, because then they're gonna find it way more difficult to take your advice.
Interesting.
All right, let's talk about the bitch.
I was like, should we rename it to the complainer? But I mean, this is our show. We'll do whatever we want.
so like I was saying, the bitch can be male or female. It doesn't have to be, sometimes when you hear the bitch, you hear a female, but that's not necessarily true. I've had plenty of male bitches. So it's tough because there's always a reason that the bitch is a bitch, right? I've
had so many parents.
Yeah, it's like they'll generally come off as not a good person. Like they'll talk down to you. They'll especially to the front office staff. I mean, the bitch will come out when you see these people interact with the front office staff. Who schedules them? Who does kind of like the administrative stuff? Who's the one that collects the co-payments? Things like that. So those are the people that really get the brunt of this.
That's true. That's true.
They, for some reason think they're better than you. They find quick flaws in your treatments so that they can fulfill their preconceived notion of what they already think is going to happen. They want to go and they want to tell their friends over mimosas like, oh my God, I had this terrible physical therapist and stuff. And
it's
this
like
is why.
They're on a mission from the beginning, and it doesn't matter how good the service is in the front office. It doesn't matter how good you are. Yeah. It really has nothing to do with you. It has more to do with them. It's their own problem because they have determined that they're going to make it difficult for you.
So it's that preconceived opinion that you have to break down immediately. And the way you do that is by showing some kind of result on day one after treatment one. And that's not always possible, realistically, in my profession, and I'm sure most healthcare field, but if you can get that patient leaving the clinic that day with a sense of, oh, I think I accomplished something. I either have less pain, I have more range of motion, or and you can do that a couple of different ways. Like I can sit a person down and do some range of motion on their shoulder, and I'd be like, oh wow, look at how much more range of motion you have now than we did when we started. Even if it's not the case, they'll be like, oh yeah, I feel that. Like it's that reassurance and like showing results day one that immediately shatters that preconceived opinion. I'd be like, okay, this person might actually be the person who can help me.
Yeah, so I'm thinking about this from a pediatric perspective, and there's a few parents that I think about, that this bitch comes to mind. But I'm just going through the reservoirs of my mind, thinking about these parents, and I know that the reason why, in my experiences, why every parent that was classified this category was the way they were, was because they were kind of in some sort of denial about their kid's diagnosis, and the whole thing of going to therapy long term really set them off. And so I'm thinking about what you said about like the front office gets the worst of it, and it's so true. And I'm just thinking like back to this one particular experience where I know without her saying it, but she says it indirectly during our interview, our patient interview, that I knew that it was because she doesn't want to admit that her child has this condition. And this is her way of suffering. Like, this is her suffering, this is her grief process.
Right.
And so of course everything was a mission in the front with scheduling, and everything was a mission with, and sometimes I took the brunt of the mistakes from the front office, because I think one time they misscheduled. There was like a weird overlap, which never happens, but it was a mistake. But of course it happened to be with her. And I'm like, this is perfect. This is a perfect disaster. So I'm just thinking the way I gained rapport with this mother, because again, the child was really young, was showing the mother that like you have to, in this particular case with like the way I was seeing the reason why this this mother was quote unquote the bitch was because she needed a lot of evidence of what the treatments that we were doing. So it's kind of like the skeptic.
She was the skeptic.
But also
it manifested as the bitch.
It manifested that way. And so she needed reassurance from everyone that like we got her sons back. And she also needed, I think what happened naturally, because I gained such a huge bond with her kid, was that what happened naturally, which soothed her, was the fact that like there was a lot of love towards her son. The way I would talk to her, I got close with her. And so like, especially with, I just want to say also, this is culturally, it depends on what culture you're coming from or what the cultures you're working with, because I'm Hispanic and this was a predominantly Hispanic culture that we were in Miami. So the way that we were able to get close with each other like reflected also a lot heavily on our culture. So like bringing little coffees, like moms and parents would bring little coffees to the therapist. There was just a lot of warmth and a lot of love. And I would show mom pictures of the things we were working on during the treatment session. And so that she could have like all this evidence of all the cool things we were doing. And then she started to confide in me all these things. And I saw her soften completely. Yeah. I mean, completely, from not wanting to work with anyone but me to wanting to work with that any therapist can see her child, because then she totally softened. She understood that like we are all a team. We're all working together and we all love our patients. Like she wanted to see this long-term relationship. And I think that's what softened her edge.
Yeah. Yeah, of course. Yeah, that's a difficult situation because she was the skeptic. I mean, that's really what it became, right?
At first she was, but that she had this quote unquote, as we're calling it, bitch attitude.
Right.
Complaining, everything was an issue, etc. And then we just saw that was a defense mechanism.
Sure. Yeah, of course. Mm-hmm. Let's move on. The next one is the flake. So the flake's a tough one because the flake is also a manifestation of a different kind of personality. So the flake is a person who misses appointments, doesn't take their meds, doesn't do their home exercise program, and generally just kind of doesn't do or seems to not care. Basically what I'm finding out is that the flake is the skeptic, but they're just not outright rude. Like they're non-confrontational. So the flake is someone who's the skeptic, but just doesn't want you to know, like outwardly know it. Right?
So they're just gonna miss your appointment.
Exactly. So the same strategy applies that you would take with a skeptic. You got to knowledge drop hard right away, so that they get on your side and they say, okay, this person is the one who's gonna help me.
Mm-hmm. Yeah. In terms of pediatrics, parents will miss appointments, no shows. Sometimes they'll blame it on little things that it's, if you see a pattern over time, like the kid's always sick, but like they're not, or like things like that. It's like the parent is not taking therapy seriously, thinks that their child doesn't need it. That's what's happened in my case. Or and so like I know different I was gonna say studios because I danced my whole life. Different clinics will have different sets of punishments, or they'll have different consequences for clients or patients that miss therapy. And I think that's just a policy, right? Because if they continue to disrespect your schedule and disrespect your time and not show up, then they're going to get kicked off the schedule.
Yeah. Yeah. That one's a pretty simple one. So we can move on again, I guess.
What's hard about the flake is, what if you have a flake and you're in an inpatient setting and
they just refuse?
They refuse therapy.
Yeah.
That's tricky. We've never been in that situation.
I mean, I had an acute care rotation, so I kind of have a decent idea. I guess if a patient refuses therapy, like if you go into their room and you're like, all right, time for therapy, there's a lot of factors that go into it. They could be, getting a procedure that day, or they could be...
They're woken up so early to get
tired,
blood drawn and all this shit, and so they don't feel like it.
Sometimes you might just have to be okay with letting those refusals go. And I think in a way, like, you don't want to be the drill sergeant, because that's not a way for you for that patient to trust you. You know what I mean?
It's hard. And actually, in my inpatient rotation, I'm remembering, because although this was 5 years ago,
inpatient rotation. You mean?
Okay, sorry.
No,
Inpatient. During my inpatient rehab rotation, I remember when someone refused therapy, my CI, my clinical instructor, would ask the patient, "Do you need to go to the bathroom?"
Oh,
because as OTs, we work on all the things. We work on bathroom mobility, and so it came less from like, we need to go to the gym and do therapy, versus like, let's just work on you getting up now and taking care of what you need. Yeah. And there was also one time where patient, quote unquote, refused therapy, but we spent that time talking about, this is so vague, I can't really remember, but we talked about, we actually turned it into a therapy session, but more patient education. And my CI was really all about me in terms of like, I think my project at the end of this rotation was, oh my God, what was it? I came up with this binder of like ideas for when patients patients refuse therapy, how you can implement. Damn, I wish I had that with me now.
Yeah.
How you can implement non-traditional forms of therapy. I dare I say, did I include meditation? Because I was not meditating back then, but I think I researched it and I included it. And my CI was all about that, because she understands that as OTs, we're treating a person, and there's a spiritual component to this person, and there's a psychological component of this person getting better. And they're in the hospital. It's not fun. So not everyone's going to wake up and be like, yeah, let's go to the therapy gym and let's slay in the therapy gym. And some people are really determined, but some people are going through their own things, and they don't want to, the last person they want to see is you sometimes. So,
sure.
So from an OT perspective, she was like, do you want to go to the bathroom? Is there something you want to talk about? And we can really, most times we turned it into a productive session. So yeah.
Let's go to the hypochondriac.
Your favorite.
Hypochondriac is a patient who really, really wants to get better. And there's someone who has a very descriptive catalog in their mind of every single symptom and exactly how it presents, and they want to tell you about every little bit. And every single errant issue that they have, or maybe something that doesn't feel quite right, they're going to tell you about it immediately. This is someone who's overly compliant, someone who does, if you want them to do their exercises once a day or take their meds once a day, they do it twice or more. It's like they think more is better sometimes. It's just someone who really, really, really wants to overdo it because they want to get better fast. This person is usually a Google scholar and a WebMD expert.
They have their their doctors.
They can convince themselves that they have ovarian cancer if they're a man, or something like that. So
I saw something online that said you went to medical school via WebMD.
Yeah, pretty much. I mean, they'll basically reassurance is super key here. Okay. They're going to come at you with a whole bunch of questions, and really you just have to take things down a notch, emotionally, and be like, make sure that they know that everything that they're feeling is something you've seen before, even if it's necessarily not. You need to say, oh yeah, totally normal for you to feel that, or totally okay for this to be happening. That reassurance, and that's going to have to happen like over and over again. Also,
like, if I really don't know something, I don't want to pretend that I know something. I mean, it depends what it is. Like, I get what you're saying. It depends what it is. But if there's like a really weird thing, and let's say I'm dealing with a hypochondriac, like a parent hypochondriacting about their child, and they're saying all these things, and I'll say, oh, that's really interesting. I'm gonna research that and get back to you, because that is whatever. I'll just say something like that, and then they know, okay, maybe if you haven't seen that before, that you're really interested in it. Like, I think the more you display your interest, like, the more you're going to help to calm them down, right? Is that in your opinion or no?
Yeah, I mean, I don't know. Just in general, they need to be reined in. And you need to be careful about what advice you give them.
Because they'll take everything you say.
Because they'll take everything you say and they'll run with it, 10 times over. I usually don't give this person like from a PT's perspective, I don't give this person too many exercises to start with, maybe one or none when I start with them. Really just getting that slow kind of, okay, let's walk before we run kind of thing. Get that going from the start.
Mm-hmm. Or what has helped me with parents that are really noticing every little thing that their child's doing and asking me, is that normal? Is that normal? What helps is also showing them maybe a developmental chart, or it depends on like how much, everything I'm saying, every thought I have, I'm like in my head, I'm like, it really depends on the context. But I have shown a parent a developmental chart or a piece of it just to reassure them that, or maybe I've also like explained things, or I've shown them different things from my assessments just to show them, to reassure them that if this particular thing they're worrying about, if it's really nothing to worry about, I'll give them some evidence, and then they feel a little more at ease once I show them things versus just them having to take my word for it. But the more confident you appear, or even if you're like, you know what, that's so interesting, I'm going to look that up and get back to you, and we'll talk about that more next time, because I remember, like whatever it is.
Yeah, obviously. Okay. Obviously, if you're a doctor and you see something abnormal, you don't want to be like, oh yeah, that's normal. But
we're not talking about that. We're just talking about like,
from a perspective that, you want to keep this patient as calm as possible. You don't want to tell them that they have, a grade 3 tear of their ACL on day 1. You probably want to like just kind of keep it a little low key to start with. You know what I mean?
Yeah, I don't know.
That's my opinion.
I think, not that we have different opinions. I don't even know, but we're just talking about different scenarios that we've encountered.
All right, let's move on. Let's talk about the flirt.
Yeah, that's happened to me.
Tell me about your flirt patients.
He had a TBI, so he was pleasantly confused. Tried to kiss me a few times, but from his wheelchair. And the other therapists were cracking up because he had a liking to me and I was a student. But we knew that this was as a result of his, change in cognitive state. It wasn't a...
Did you have any like non-neurological patients that were flirts?
Yes.
Yeah.
When I worked with patients that had Parkinson's and strokes, they were old guys. They were in their 70s, 60s, 70s, 80s. And some of them flirted with me. I was a young girl, a young therapist. It was innocent flirting. It was nothing where I felt like creeped out about. Although this is their way of displaying to me. I mean, is it right? I'm not sure. Like, it wasn't the way. I never felt like they took it too far. It was very innocent flirting. I think it was their way to play around during our session, to talk, just to like make conversation.
Yeah, I think typically it's always going to be an innocent thing, and this can go for, it's usually like an older male or an older female. I guess that could happen too. I mean, that's happened sometimes with me, not that often, but it's typically very, very innocent. But if it ever becomes not that, obviously, this patient is gonna want to request to see you, and only you usually, if there's like other therapists or providers in the clinic. So just if it makes you uncomfortable, put your foot down. If not, sometimes that can be your best tool to keep them compliant. If they want to come see you, they that flirtiness is like a product of like they just trust you, right?
I think you have to document all of this. Everything we talked about, any behavior from your patient, if they're a CEO or a bitch.
I never document on personality traits. I never do that. I don't know. I'll make a mental note because I mean that's not something that I can quantify in a note. You know what I mean?
But when I document anything that's okay, maybe that wasn't directly related to the session, and again, I haven't had a flirt. Like, okay, I have had flirts, but this wasn't a part of my documentation. But in pediatrics, there's a lot more room for narratives. So if there have been really, especially with kids, you want to note their behavior. I think we're talking about something different, because then the kids' behaviors, or maybe the parents' behavior, like maybe they were late, or I make notes in my note, even though it's maybe not necessary, but it's everything. I'm keeping track of everything that can interfere with our session, whether it's a parent's behavior, or whether a parent reported they were non-compliant, like a flake with home exercises or whatever. These are just little things I'm thinking, like, I do document because I know, like, it always comes back to if a parent takes, for example, if a parent divorces and like these are documentations taken to court for whatever reason, it's everything has to be to the best of your ability documented.
Yeah, I guess that's true. I mean, I document non-compliance,
right?
But I'm never like, patient was rude to me,
No, I know what you mean, but
all right,
okay,
all right. Next one. Okay, we have two more. This one, I named the Ancient, and that's a completely loving term. Okay, it's not to talk shit or anything, but. Basically, the Ancient is someone who's really, really old. They've lived way longer than they even thought that they were going to, and they'll tell you that, and they'll joke about it. Their systems are not working how they used to. There's hardly any cartilage left in any of their joints. They have pain all the time. They can hardly move around. They don't have to be a nasty person, per se. In fact, typically they're pretty pleasant, but they've surrendered to the fact that modern medicine isn't going to make them any younger. So sometimes it's hard for them to kind of take what you're going to go in there kind of gung ho, like, oh, this is going to help you do this, and I can't wait to get started on this and that, and they're going to be like, dude, I've lived for 90 plus years, like, I'm not that interested, like, it's not going to be a miracle. And they're right. So basically what the Ancient wants is they want like a straightforward, like, no BS assessment of the issue that they're coming to you to see, what exactly you're going to do, and, that it's not going to make them young again, but that it may help them, like,
move better,
manage their pain, or move better, or something that makes sense to them. Like, can they transfer more easily out of their wheelchair, or can they roll over in bed without assistance from others, or can they go to the bathroom without assistance from, small things that help their quality of life get better. Those are the things that you have to be, super just like, yeah, like, I might not make you walk 100 feet today, but we'll work on getting out of your chair and standing a little bit, and that's okay.
Yeah. When I was working with the older adults, that had mainly Parkinson's, many of them were not interested in becoming any, like, they weren't interested in becoming athletes, but some of them were really into their personal shape and their fitness. So every patient wanted something totally different, and it didn't matter the age. But the patients that were, again, skeptical of, why do I need to come? Like, I'm moving just fine, but they're not, because they're not moving fine at all, and there's a lot of fall risk. So just tying it back to, we're doing this exercise because it's going to help you walk around the community better, or it's going to help you, walk to your kitchen better, and whatever it is, like you said, like tying it to function. Because when I've worked with patients that are pretty old, again, they're not interested in doing much more than what they have to. So you have to really demonstrate the importance of these exercises that are going to help them to get up from a chair better, or to get out of bed better, those type of things.
Yeah, I think it's important to temper your own expectations for what you're going to be doing with them.
That's a good one.
Putting your taking some really good looks at your goals and being like, okay, is this too lofty for them?
Yeah, that's happened to me. I make really elaborate goals. I've always done that.
Yeah.
And I learned in this Parkinson's neurological experience I was in, I learned that you need to simmer down the goals and make them more practical and have realistic expectations.
Yeah. Let's do the last one. The last one is called the know-it-all.
Isn't this like the CEO?
So the know-it-all is kind of like the CEO. For some reason, they believe that they're a better clinician than you. They know all the things already, and whatever you tell them is like, I don't know about that. I'm going to do my own thing. Like basically the main strategy with this person is they need to be shown, not told, that what you are telling them to do is the right thing. For example, from a PT perspective, if I have a know-it-all come in, right, and they're like, let's say my shoulder hurts, right, and I'm going to say, okay, well, for my exam, these are the things that I think you need to do in order to improve your pain. And if you don't do them, it's probably going to get worse. If they're skeptical and they're know-it-all, they're going to be like, I don't think so. And then they won't do the things at home that I want them to do, and then they'll come back and they'll be worse the next day. They need to see that kind of stuff happen. And then on the flip side of it, let's say I give them 1 or 2 stretches, they need to see the improvement that comes from that. It's like they need to be shown, not told, because you telling them something doesn't mean anything in their eyes. They need to see the results and see the actual things happening that are helping them.
I think of know-it-alls, and I think of actually having been a fieldwork educator. I think of know-it-alls in terms of having students that come in knowing it all. And I've had a few of those, and I've also, when I was a student, I've had was a student at a for example, like at doing a field work, or even after I got a job when I wasn't a student anymore, just seeing other students under supervisors and seeing it from that perspective, which I just thought of now. I wasn't planning on talking about this. But just being a know-it-all student, it's like the worst thing. It's like,
it's kind of an oxymoron.
It's the worst. Yeah. If you're listening, I know you know better.
You need to have you need to have an "I told you so" moment with these patients. You need to say, "Oh, look, you didn't do this, so now you're worse," or "Oh, you did this, and now you're better." You need to have that kind of "I told you so" moment, because that'll put it in their mind that, okay, maybe this person does know better than I do what I need. So basically, that's the main strategy with these people. Mm-hmm. And that about wraps it up. If we missed any particular personalities, let us know. So yeah, hope you found some benefit, and hopefully you can implement some of these things with patients in the future, and let us know if it helped you.
Yeah, we would love to get emails from you or direct messages on our Instagram, burnt out to lit up, or you can email us at, what's our new email?
podcast@joyenergytime.com.
Yeah, so we would love to hear your feedback. And this was from our experiences and us, like me thinking out loud a lot. So just send us whatever feedback you have. If you have worked with these type of patients, or maybe there's a new category of patient that we didn't touch upon, or what your experiences are, we would love to hear it.
Okay.
Adios.
Happy Black Friday. Go shopping.
Online.